Hello and welcome everyone. Thank you for joining today's webinar. The webinar today is 5 key factors of business sustainability. We will be talking about analytic tools and solutions for health and human services. And I'm Carol Clayton. I'm a senior associate with Open Minds. I'll be facilitating the webinar today. A few housekeeping items before we begin. This session is being recorded. You will receive a link of the recording in a few days, as well as the materials. So please be on the lookout for that. And we hope that you will find it informative. You can share it with other people within your organization who might not be attending today. So please be looking out for that. Also, if you do have any questions, please post them in the questions component in the GoToMeeting software. We will be entertaining questions. We are looking forward to having both an informative and engaging discussion, so please post those and we'll address them at the end of our session. But now I'd like to introduce our presenters. Steve Keller is President and CEO of iCentrix Analytics. Steve has over 30 years of experience managing the development of software applications in a variety of disciplines. Data warehouse, business intelligence systems, management information systems, decision support software. He's one of the smartest and engaging people I know. And he spearheaded iCentrix Analytics Business Intelligence and their KPI analytics, their warehousing initiatives, all in the area of behavioral health and developmental disabilities. And he's led over 200 data warehouse and business developments for behavioral health providers. So Steve, we're delighted that you've joined us today and sharing all of your wisdom and your experience, particularly in the field of health and human services. Steve is joined by Robert Beckley. Robert is a clinical informatics analyst. He works for DuPage County in the state of Illinois State Health Department. Rob started his career in inpatient behavioral health, but he transitioned to public health a little over 25 years ago and has been in public health since, working at all levels of care. And this has brought him a tremendous experience as well, implementing behavioral health, at least 2 behavioral health electronic health records, consulting on implementation around environmental health, and also centralized scheduling for over 100 employees. He regularly uses analytics data, clinical, financial, and administrative, to really help sustain the county health department's businesses. And he's developed a number of best practice workflows across multiple operations. And that's really, Rob's here to share how he has been able to use analytics to really sustain business. And so just delighted to be joined with you both today. This webinar is brought to you by iCentrix Analytics. If you're not familiar with them, I hope this allows you to get to know them a bit more, and maybe you'll spend some more time learning about them afterwards. But iCentrix is a leader in business intelligence and actually is the leader in analytics solutions for behavioral health organizations across the country. More than 20 years of experience, so not a new software off the shelf here. Analytic solutions that are being used to help manage revenue, reduce cost of care, improve outcomes. And as we move into value-based contracting, and particularly a CCBHC model, the iCentrix solution really has a very strong foundational component to helping organizations sustain their businesses through emerging revenue models. iCentrix has also developed an IDD-specific electronic medical record that's already being used and touching 13,000 lives and being used in certain selective states. But if you'd like to learn more about that, please visit iCentricAnalytics.com and you can learn more about that very unique solution as well. So with that, we are here today for an hour together to look at 5 key factors: performance reporting, bridging the gap between clinical and financial data, staff productivity and how to use data to help manage staff productivity and revenue cycle management, looking at clinical productivity and how to identify missed opportunities, And we will end and focus on revenue cycle management today. And I think Rob will be sharing with us a live demo of the solution during that session. So just going to pass it over, Steve, to you now for some opening remarks, and look forward to what you have to share with us today.
Well, thank you for that introduction. So our title is Business Sustainability, and if we're going to be able to manage our business in a way that it's sustainable, I think we all know that that impinges upon the notion of performance reporting. In our industry, we have experienced many instances where providers develop automated productivity systems, for example. That's on the clinical side of the house. On the financial side, we're going to see different information typically used, most often sourced from the general ledger versus from the EHR. And so we've worked in the industry for, as Carol mentioned, 20 or so years. And what we've noticed is this sort of gap that we see between the clinical side of the house on the left and the financial side of the house. When we work with those departments, we find they're talking different language, as you can imagine. Financial talks about cost centers, clinical talks about programs, financial talks about line items, clinical talks about payers, etc. And so through the course of that work, we noticed that it's very difficult for financial people to predict their revenue. And this is kind of reflects that notion that we're using different measures on two sides of the house. You can see some of the kinds of things that are typically measured on the clinical side. I mentioned productivity, but if we go to the next slide, you can see a little more about that, where basically fundamentally on the clinical side, we tend to measure steps in the clinical life cycle, which is all good. It gives us a chance to measure weak points in the process. So for example, if we're going to achieve productivity, we're going to need to have enough clients in our programs to generate enough appointments for the staff so that the next week their appointments can be realized as productive hours, right? So one weak point could be we don't have enough appointments in the calendar, and that's because we don't have enough clients in our program relative to the number of staff. And as we move through the life cycle, we can think about measuring things like no-shows, billable versus non-billable hours, and so forth and so on, as I think most of you are probably familiar with these kinds of measures. So that's great, and we build a lot of dashboards around these, and they're very useful tools that allow people to drill in and gain insight into the clinical life cycle. But it leaves a big question, which is, how much does that matter for our revenue stream? Like what's really driving changes in our revenue stream with respect to a particular program? And that we want to address a different way. You know, the idea is we don't want to spend our time breaking down a program's no-shows by staff if that's not, from a financial point of view, if that's not a big impact on our revenue stream at this time. Let's stay away from that and let's focus on what's driving it. So our approach here that we're going to be talking about is starting with revenue and looking at what's contributing to the variability. So for example, if we have a mean performance on revenue for a program year to date, and we see a drop by, say, more than a standard deviation away from that mean, we're recognizing some variability. And the idea is we want to understand where that's derived from on the clinical side, because if we can figure out which part of the life cycle and which structural component of our organization is contributing to that, we can use that as the first step in a course to action, which is ultimately the goal, right? We need performance measures that can lead us to action. We need measures that give us insight and tell us where to look. So this is kind of the introduction, is the idea of understanding our revenue variability and being able to express that in terms of the measures that we use on the clinical side. So that's kind of, and we'll see maybe a little more. I mean, I could talk more about it, but I think we want to use the approach of looking at examples to illustrate that idea.
Yes, great
So with
idea.
that,
Yes, go. I'm
I
sorry.
was going to say with that, we can turn things over to Rob if you want to jump in.
Yes, just a couple of comments, Rob, before you go. Steve, I really liked your comment about reducing variation. From a clinician, and we're going to talk about the divide between, clinical staff and how they communicate and financial staff. A key for clinicians, reducing variation in care around best practice is something we understand. I'm a psychologist, right? So when I hear reducing variation, I understand that you want to reduce variation because the closer you get to best practice, the better outcomes you have. And I hear you saying that is true also when you look at your analytics around your financial data. And so I like that concept of reducing variation. Rob, I know you've got some case studies. I'll share one more example. My daughter is an early career health and human service organization person. So she's in her first year of employment, and she's the ACT team coordinator. She discovered that for the clinicians on the ACT team, if they didn't document and bill within a certain number of days of their service date, they only would be reimbursed a penny on that service. The clinicians had no idea that occurred. And so here they were just, nobody was monitoring that, oh, you were 61 days out, so therefore it becomes a penny. And she was able to say, look, we're leaving all this money on the table, but nobody had told the clinicians. The social workers had no idea. And so, Rob, I'll pass that over to you, but I think that's probably what some of your examples will help us with really understanding the importance of using data in this regard to bridge that gap in communication.
And Carol, that example is really apropos because we've seen that's a good instance where staff are overwhelmed with the minutia that they're supposed to keep track of. Finance cares about revenue. Let's think about a way that we can make it easier for the staff to keep track of what's hanging out there. Mm-hmm. And it's obviously, when we talked about at the beginning, the notion of analytics tools, that's a good place for an analytics tool because it can, yes, if it's used, if it's developed in a way that everybody understands the meaning of it, it can be a really important tool for gaining traction on increasing revenue. Mm-hmm. Mm-hmm. So having said that, off to you, Rob.
Thank you, Steve and Carol. So as you've already heard, clinical and financial kind of speaks two different languages. I, by trade, am a clinician. I had a CPA as a father, so I do the analytics as well. And I really got interested in this because there was a big disconnect. And the example that Carol just gave is kind of illustrated what's here. On the left-hand side, we have productivity. Supervisors, staff, whatever, they look at the amount of hours or minutes, whatever. And, in this example, we see that, there's a downward trend happening in the clinical hours. And when talking with finance is going, oh, things are great, and that would be the opposite of the example that Carol gave. But in this example, clinical isn't doing as well. They actually dropped significantly, and they come in, and on the right-hand side, financial saying, wow, no, there was, a $50,000 increase in revenue. And, what are you guys doing different? And then they're both looking at each other going, oh, we're not doing anything great. What's causing that? And, one of the things that I was big on was what is the common denominator? And the closest common denominator that I found was units. So if you go down to the slides that are right below, you have the billable hours and the units by month. On both of those, the expected amount by units by month. When you start to take a look at that, and I have done in kind of a table below, you begin to see that, they're looking at the same information, but it definitely shows something different. There's definitely a downtrend going on in billable hours. There's an uptrend in reimbursement or expected amount. So one of the things that we agreed upon was that we would start to take a look at units. like kind of on the right, I put, units equals units. It's an apples and apples, comparison. It is not exactly 100% comparison because there are other variabilities that go into units, such as group units. Psychotherapy is just one unit, whereas therapy counseling could be 4 units at a community behavioral health center. So there is still some variability, but what this brought in was a better ability for the clinical team and the financial team to be able to at least have a common denominator that they're working with. And that kind of leads me into the next section, which is staff productivity.
That's really a great example, Rob. And I'm thinking about another client I've worked with, but what you're talking about, and Steve, you alluded to it earlier, it's common definitions. Like, let's get language that we can all agree to. And so now we know we're doing apples to apples. This is not easy. This is not easy work. In this particular client, they were trying to figure out why their revenue was down post-COVID, like they had not bounced back. And they couldn't understand why they hadn't bounced back because they were doing a lot of telehealth and people were less likely to no-show with telehealth. And so how come our revenue hasn't bounced back? But the data was very messy in terms of like, how do you have common language to know what to look at? And a lot of it had to do with, I see some of your bullets here was it vacancies? Was it referrals? Was it caseload management? What were all the variables? So talk to us a bit about this, because it is about getting down to root cause at the end of the day.
Very true. And as you mentioned, one of the key bullet points here is caseload management. Before I jump into that, I do want to say that, there is a large, in my opinion, part in which the agency plays a role in caseload management, centralized scheduling, filling vacancies. And that has just as much bearing on productivity as the clinical staff working with the client. And a lot of times, as a clinician, it was like, why is your productivity low? And there's some things that were not in my control. I can engage the client. So some of these things that I'm going to speak about are things that the agency can kind of deal with and look at it through kind of an analytic tool. In this example, I'm looking at caseload size and client engagement. I've got 4 prescribers here over a period of time. They're all full-time prescribers. And if you look at this, I've got blue billable hours kind of in a light blue, the purple or the purple dark blue is number of services and number of clients is in orange. The no-shows are in kind of the table below. But when trying to compare, the amount of hours and how many services are provided, these top 2, Cocoon and Kaja, they're close in hours. They're fairly close in the amount of services, and they're pretty close in the amount of clients. And if they're hitting where you want them to be as far as productivity goes, if you're going by hours, that's great. But what about the lower 2? Are the lower 2 what is different? And what I see different is that there is a difference in the amount of hours that's being billed. There's a decrease. It gets kind of the decrease is much larger on the very bottom staff, but also the number of clients is very low. And they're going to do their work. They're doing awesome work. But one of the things is that they don't have people sitting in front of them. They can't do anything. And I always go back to saying, kind of very simplistically, you either have too many clients, and that then creates a very long wait between appointments because you just can't, schedule them soon enough, and they kind of lose interest and they no-show. Or you don't have enough clients, and there's, you're going to be sitting there with nobody in front of you, so you can't bill. So, I think it could go both ways, but, this is a way to visually compare, staff to kind of see what are some of the variables. Some of this could be client engagement. I put in the no-shows here. This is not a large spread in no-shows, but you know, the two folks on the bottom two rows have a slightly higher notional rate, but that doesn't seem to really impact it because somebody that's doing kind of what they need to do has a higher notional rate. So I don't want to say it's simple, but this at least gets you to a closer, more defined area that you could then potentially, you know, kind of focus your time. We also take a look at kind of staff and program assignment and kind of missed revenue or opportunities. And in this example, I'm showing basically the billable hours, which is in light blue, the units that's in purple, and then the number of clients. I'm really kind of most interested in, though, the billable hours and units. And what I'm showing here is an adult case management or adult therapy or outpatient program. And primarily Medicaid clients. This program has both licensed staff and unlicensed staff at a master's level, and they primarily are doing therapy counseling. And I'll have a slide that I'll be showing here in a minute. But you know, in that, they're doing therapy counseling. And when I take a look at this, you know, what I'm really interested in is the Medicare, the MMAI, the Blue Cross Blue Shield. These are all kind of what we call commercial payers, and they are the payers where we submit psychotherapy or a CPT code. And in this example, I'm looking at one, you know, staff assignment and program assignment. Is this because at the front end we didn't assign them correctly? Whereas, you know, a Medicare or somebody that's got commercial insurance should be with a licensed individual under kind of a psychotherapy program. And that's where then I get to see that there's, you know, a whole lot of hours, units, and number of clients that are actually potentially getting kind of lower reimbursement services. Is this going to make the bank? No. But this is just one program for a very small period of time, and no money, no mission. So any opportunity that we can have, you know, even if it's a quick snapshot like this, you know, these clients themselves could then be put into the correct program where they'll get the same high level of service. Not saying the service is any different. It's just how it's billed is dependent upon the payer in which they have. One of the nice things is in 2024, if some billing people will understand this, but licensed clinician or clinical professional counselors or non-LCSWs will now be able to bill Medicare directly. That is something that came out. You know, Incident 2 is kind of a process that is not easy, lots of hoops to jump through, but it made it very difficult. And I might assume that maybe some of these clients that are with this adult outpatient, you know, might have kind of slipped through the cracks because we had to do this extra step. So the good news is that in 2024, you know, the licensed clinical professional counselors or whatever your state calls them will now be able to bill Medicare directly, which is great on multiple levels. So being able to control staff assignment and program assignment could help make kind of missed revenue opportunities a little bit less, but it's going to happen.
Yes. You know, Rob, I hear a lot of health and human service organizations, they don't even bother with Medicare. You know, they just, talk about missed opportunity, you know, they just sort of let it go because it's too cumbersome and complicated. But what I'm hearing you say is that one of the ways you can use your data is to really understand your Medicare population going into 2024. There will be this ease of regulatory requirements, I guess, and set up your systems, go after that revenue. Make sure that you're matched to the right clinician type and begin to bring that in. And I think to Steve's point earlier, you know, be able to anticipate, forecast what you might be able to go after with that Medicare population that you might have ignored in the past. At least, maybe not so much new, because I know you're in a health department, but I think for those who are specific to behavioral health in the past, it's just sort of like, ugh, not going to bother with Medicare.
Very true. You know, it's enough bureaucratic stuff that staff have to go through on the clinical side that the behind the scenes staff have just as much bureaucratic stuff. So going into 2024, you might have a great
Oh,
opportunity.
you do? Okay. Yeah, cool.
Another piece that we have is, you know, when you're scheduling, you know, I said it's the agency's kind of responsibility to assign clients, to assign them to the correct person depending upon the payer. But there's also some other things that can help a clinician that really needs the agency to input into place and then monitor and control. And in this example, this is in just-in-time scheduling. I'm sure many of you have heard about it. It is very popular out in the world. We kind of morphed it a little bit due to multiple agency constraints. But as in this example, I've got our number of staff or our prescribers here. And kind of the rule of thumb is that you're not supposed to schedule out past 2 weeks. That a client calls in, they're running out of meds, and you basically have 2 weeks before they run out of meds to get them in. This basically reduces no-shows. And we have our highest paid staff, and no-shows can be a real negative consequence. What I'm showing here is over a course of weeks, so not by months or anything like that. I'm showing how many services are being provided in the future. So I did this at the end of August, and this is a snapshot from the 31st of how many clients were scheduled in the future. And what I see here is that we chose 3 weeks instead of 2 weeks. And the orange line shows me that there are additional clients that are being scheduled after that 3 weeks. One might say, who cares? Well, you know, results show, or the analytics show that, you know, if you start to go too far out in your appointments, that, you know, you're going to have a higher no-show rate. And, you know, in this, I was able to identify, that's kind of why you see some of these darker highlighted prescriber names in bars, is that I was able to identify which prescribers kind of fell into that era of, you know, scheduling outside. The numbers on the far right, don't let that fool you. That's for the entire time period that I put in here. But when I'm clicking on these, it basically will then tell me how many clients are, you know, scheduled after the 24th, which would be 3 weeks after when I took this particular slide example. So, you know, is a clinician going to do this? Is the prescriber going to do this? No, it's a front desk thing. It's our centralized scheduling, but it's something that needs to be monitored. And my dad always said, it's not what you expect, it's what you inspect. And not that that's a, gotcha, you're doing something wrong. It's, if it's not worth it for you to inspect that things are going the way you wanted it, have an opportunity to ask questions, to clarify what the goal is, to make adjustments because things aren't working, then more than likely you're not going to get exactly what you would expect.
Mm-hmm,
Okay?
mm-hmm.
You know, in this case, you know, again, it's not going to break the bank, but every little bit counts. Again, these are highest paid prescribers, and, you know, you increase the no-show rate a little bit, you know, that impacts the bottom line,
Mm-hmm.
which can be problematic.
What did your team do, Rob, once you can see the number of patients that are scheduled 3 weeks out? Did your centralized scheduling start to work to offer them an earlier appointment, rearrange, you know, clinician schedules in order to move them forward, or what exact action was taken with the data?
A great question, and it's an ongoing question because we've implemented this some time ago. We went and basically are able to see kind of with using analytics, who are scheduling these.
Mhm.
And looking at that, we can say, okay, that's centralized scheduling, or that's our intake folks. And we can have a conversation with them. And sometimes, not saying this is the instance for this, but we don't have enough spots,
Yes.
and looking at the ones that are highlighted, kind of like, well, the majority, if not all of these are full-time staff. So
Mhm.
why is it that there's so many that have so few or fewer
Yeah.
member services? Sometimes it's like, well, the client can't get in. It's like, okay, well, that's fine. The likelihood, though, of them showing, why don't you tell them to call back when they're closer able to actually attend? We did find also that there were times where their rogue staff, I don't say they're not malicious in any way, but they would go in and try and help out a client, and they're like, oh, the client needs to see the prescriber, and they would put them in the schedule, not really remembering, because that's not what they do, to not schedule them after 3 weeks.
Uh-huh.
And then what we would expect to see, and then it would be kind of, it's always a moving target, is that we would use something like this where we then go week by week, and the hope would be that we would begin to see like that 84 number, if there's any people that should have been seen earlier, were seen earlier.
Mm-hmm. Mm-hmm. Neat. Very neat.
So, again, just-in-time scheduling is a great way to be able to kind of have a missed opportunity with prescribers, but there's also some behind the scenes that you still need to do. So I've talked an awful lot about kind of what an agency can do or should do. Something that we've not done yet, but I am slowly broaching the subject, is, this is very similar to third next available appointment. And the concept is how many days, calendar days, would a client expect to wait before they get a service? So very similar to what we're seeing here, where we only wanted them to be making appointments up to the 17th, the week of the 17th. We want to find out what is that magic number of days to maximize engagement, meeting the client's needs, and also meeting the agency's needs. We're here to help clients. Everybody's dynamite at helping clients. And sometimes we just miss the boat because sometimes we're not monitoring what we need to monitor. And the third next available appointment, if you're not aware of it, just Google it. It is an interesting concept to be able to do this. A couple other different ways for centralized scheduling. This is just a different way. You could go by day. So I went by week. Now I'm going by day. I've included the no-show rate. And in this example, our no-show rate is lower Tuesday, Wednesday, Thursday. And, we might have opportunities, hours of office being open, staff scheduling kind of their shifts. This might be an opportunity where you might want to kind of heavy load the midday weeks, and on Mondays and Fridays kind of have them where staff are doing training, they're doing their catch-up paperwork, the other things that don't involve clients needing to be in front of them. And just another example, this goes by time of day. Our clients have needs, and a lot of our clients, and this is for our adult outpatient, they're working. And this kind of shows that by the change in the no-show rate. They're taking off the first part of their shift. So our 8 a.m. slots are fairly low. You go to the lunchtime hour, they go over lunchtime, 12 to 1, lowest no-show rate. And then the latter part of a day for them, 3 to 4, again, has a smaller no-show rate. For this particular program, that tells me that, we might need to expand when we're doing some of those appointments to maximize on it. We might have staff that in the beginning part of the day, they've got blocked out time so they can do paperwork. Maybe they need to do a clinical appointment. You know, same thing with kind of at the end of the day, at the end of their days, 4 or 5, instead of doing a catch-up time, that might be when they're seeing a client because that's where the client's need is best met. And as you can see here, love my lunch. I'd stand up and show you my belly because my belly does not discriminate on food one bit. Lunch might be something where you might have to have an earlier lunch or a later lunch. Yes, it's an inconvenience. And again, it goes back to our client need. We all want what's best for our client. And what's best for our client is to actually show so they can get the services that you provide. So these are some things that I think are really important that an agency can do in collaboration with their clinical staff. But it really takes us taking a look at the kind of the numbers and using Icentrix. We're able to do that pretty quickly, and it doesn't take a lot of work. So it's not a one and done. It's kind of you have to set up a cadence. How often things can change. Summer hours can change drastically depending upon what clientele you're doing. So it's a way in which you're able to be more nimble when you're able to access the data more accurately and more quickly. Staff vacancies. This is one that's always in conversation. It's like, well, we're down. The clinical staff are saying this in the meeting. It's like, well, how many are you down? Well, I don't know how many staff I'm down. We had so-and-so, we had this and that. And then it becomes a conversation after the fact where they have to go and they dig in numbers and they're trying to find, okay, someone was off ramping, someone was, ramping on or just hired. It's really hard to do productivity and kind of look at numbers when you're doing that. So in this example, I understand it's a lot to look at, but the employee actual productivity, that's what staff did. The target hours for the employee, that's what the target is. So the employee needs to meet this target hour. But then we have a position target, and that's how many positions we have. So looking at this, basically we're looking at all 3 bars to show us where might we have a vacancy. And then we can maybe more realistically identify why a certain position and or program might be not producing as much. And then it's not so much a part of, you got to go talk to staff and get them to ramp it up. It's more, you got to get people in the seat. It's no longer a clinical issue. It's like getting somebody in the seat so they can work with clients. So in this example, and I apologize, the boxes are a little bit off, but the first 2 are positions W008 and W010. If you look at the bars, the light blue, kind of the purple and the orange, they're pretty close together. The key here is the purple and the orange. If they're really close together, that means that your spots are full, that you actually have people in those positions and the employee targets all added together. In this first example is 590. Okay, that's very close to what the target position need is. You go to the second one, same thing. Okay, they've got full staff, but staff are not quite getting it. So there's an opportunity to work with the clinical staff. You go to the third example, which is WA09. Okay, here's a different story. Here we clearly have, there's been a vacancy. And depending upon, how you do your hours, your teams, and your positions will determine kind of what this will look like. But in this example, it's very clear that there's, a staff opening. Is it a full position? Is it just somebody just left? Is it FMLA? Those are more actionable than just saying, well, we were down staff. And, on the very far right, where you see some very large differences between the purple and the orange, those are very clear, that we don't have enough staff in those positions.
Yes, you can tell that. How do you, Rob, use this for future budgeting, like for your next fiscal year? Will you use a factor of anticipating, I'm going to make up a number, but let's say you anticipate 12% vacancy. And so instead of building a revenue based on 100% target hour by position, you do it by target hour for 88% of the positions. Do you adjust that, just assuming there's always going to be vacancies, and kind of look back to project forward?
I mean, in all honesty, this is something that I'm wanting us to move to. This is actually a slide that is not from my agency. I'm aspiring to want to go there. And
You're
I've talked
aspiring there, yeah.
guys, because what we've done, and this will come up in a little bit, is we typically do, the amount of hours. We look at
Yeah.
last year's and project. So that doesn't really necessarily take into account the amount of vacancies. It's just kind of a ballpark.
It's ballpark, yeah.
And sometimes that doesn't do as well.
Yeah.
And, I'll kind of show that in a little bit. But so these are things that, kind of agency can do. Vacancy plays a much larger role in productivity than one would imagine. And kind of implementing something like this, I'm hoping ultimately that, if a program's down, we'll be able to go and say, okay, you know what? I'm going to click on the program. And it's going to show me what these positions are for that program. And at a quick glance, I'll be able to say, we're down staff.
Here's the intervention that we need to focus on. Yeah, very good.
Yeah, this slide is a good example of analytics that can lead you to take action. And Rob mentioned this is not from his agency. Carol, you mentioned the tie to budget. In that case, if we have our positions tied to the budget, if we build our budget out of expectations for each position, and we build a chart like that, it points to underlying causes as far as why we might be under budget. And the chart, it is a little busy, but it's visually almost apparent that the biggest gap is the difference between the orange and dark blue lines versus the dark blue and the lighter blue. And it points out, really, this is a good example of when we talk about analytics. Sometimes people look at the visual and they say, hey, can we put a label on that? Can we fine tune it? Can we change the colors? But the real point of this visual is you can look at it and immediately determine that we should be focused more on dealing with vacancies than we should on how can we increase productivity of the staff, because the gap is much bigger there. And this agency actually took that action and redesigned their HR processes and recruiting, raised salaries, right? And we're able to focus on hiring to fill
That's
the vacancy.
great. Yeah.
So that's kind of the idea of taking action based on analytics.
I think that's excellent. And I think, Rob, leading into your next section here, it is about root cause, Steve, because clinicians often feel like they're just being flogged, right? Like, I'm just going to be flogged to do more, but it's really, really teasing out where is the fault line. And
where's the opportunity, right?
Yes. Yeah. So carry on, Rob. This is excellent.
Yep. And being mindful of time, I will spend quite a bit of time on this, but I do want to get to the financial stuff because I'm super stoked about that.
Yes, I want to see the live. Yes.
We're going to have to go fast.
Clinical productivity has lots of what we've already talked about, but this slide basically this is showing programs that are group related, and in this highlight, I'm looking at similar amount of billable hours, but the amount of units is disproportionate to the ratio of billable hours. And this would be a way for our supervisors to be able to take a look at, do we have less people attending? Do we have more people attending? Why do we talk about groups? Well, groups are less resources and basically serving more clients. They're not always the easiest. Sometimes they're more billing and stuff like that. But you could show kind of the use case or the business case of groups are really kind of important. I could have included here expected money and see what the difference is. But that's a different modality. So that's staff and staff engagement and staff enrollment in groups. Or client enrollment in groups kind of go hand in hand. This next one is kind of something that I alluded to a little bit earlier when we talked about program mix and case assignment. This is, again, adult outpatient services. And I'm kind of taking a look at a snapshot of time. And I want to see kind of the service mix. What are they doing? What are they billing for? And in this example, it's like, yeah, okay, yeah, they're doing what they need to do. They're doing therapy counseling individual. They're doing the individualized assessment and treatment plan, the IETP. They're doing therapy with family present. But I noticed something. It's like, what is this case management mental health? And what's this case management client-centered consultation? I've got those two boxes kind of hidden or highlighted with the red box. It's like that service mix is not really what we'd expect to see in an adult outpatient. It's going to vary by agency, but in this case, this is identifying that we have an awful high amount of services being provided that a case manager should do. And that's not always going to be the case. So, your agency needs to determine kind of what's the threshold. But using the analytics, I was able to actually click in and see which staff are at the highest amount. And Cassidy and Yvette are kind of the higher staff. I don't have to go to a whole team meeting and say something. I can go to, Cassidy and Yvette and just say, hey, we're kind of noticing this. See if it's legitimate or not. See if maybe a case manager needs to assist them in doing some of this stuff. Again, kind of the service mix needs to match the patient acuity or client acuity, and also with the program that they're involved in. When we take a look at client engagement, this is an example where wanted to see, how many clients have been seen. Sometimes cases go like that. In this example, I'm going from June 1st to the end of August, and there was an interest in kind of lessening the amount of clients that haven't been seen in 90 days. So we've got our date range. I put in there not seen. I put the manual in there 90 days. And at the end of August, we went from 115 to August where there's only 72. Okay, tells me then, what percentage is being seen. Okay, 94.2%. Seems really high, but you still have 72 clients that haven't been seen in 90 days. If you take a look at the details section, this then lists the clients that haven't been seen in that time frame. It provides information so you don't have to go ask staff, what clients haven't you seen? This tells you it. It tells you what type of service they had last. So the first top two, I see non-billable case management. That's what that activity stands for. That was outreach. So, is this maybe a client that a case manager needs to do the reach out and say, hey, what's making it difficult, or what barriers are you experiencing so that you're unable to participate in your treatment? Can I help you with that? And then, re-engage them so that they can get back to the therapy counseling, which was originally intended to be provided. So again, actionable, you can clearly see who these clients are and move on it. These are some things that I put in here. Probably should have put them in a different order. So I apologize for that. But, failed claims are, stuff where staff kind of did their work, but there might be stuff missing. This example is not staff related, so apologize again. But this is a new program that we'd set up, and it got set up in August. And there's this no fee matrix set up for that procedure. And okay, I've got 487 of those. What I can then easily see is what two programs are the highest producer of that type of error. And with the click of a button, these plus signs, I'm then able to see what are those procedures. And I see that it's ICC monthly case rate, HFW monthly case rate, and individual support services. So now I can go back to my billing team and say, hey, we need to have a fee matrix set up so that you can actually get these out the door. And then the same holds true with kind of failed activities. This definition for our EMR means that something hasn't happened that a clinician needs to do before it can even generate a claim. And in this example, no authorization, a lot of times that's not in our clinicians' wheelhouse, but they might need to provide information to our authorization staff for them to be able to submit for additional authorizations. And then no diagnosis. what I was able to do there is I, basically clicked on my intake team because that's where I've got $2,700 sitting there out of 10,000 during this period of time. And then I'm able to take a look at, okay, where are my higher producers of kind of no diagnosis or their clients have no authorization. Again, very targeted, focused areas that you can then go to and have kind of just-in-time conversations.
Yeah, take us out. Yeah, I was going to say, take us over, Rob. Show us the revenue cycle management. We've got about 10 minutes, and if we have a minute or two for questions, great. While you're navigating over, what I love what you're showing is that it's clear that you take it down to something that you can actually act upon. And also the rule of change I have always heard is that you have to pull between 4 to 6 levers at once in order to have a real impact on change. And you're showing us 4 to 6 things at least that you could do with all of this information you have in front of you. You can't just do one thing. You have to be able to do multiple things at once. And you've given us some really great examples. So just appreciate you sharing all of your experience, really. Yeah.
And, the credit really goes to, Steve and his team. Our team has done phenomenal work with them. They work collaboratively, but the ability to put our data in a place where we can do this.
And call on that outside expertise that you have in your partner is really key. Yeah.
Yeah.
Excellent.
Clinicians weren't meant to do, finance and counting numbers. Not all. But this is an example. I'm actually in our system.
Okay.
A very, very large span of time. This is where you're seeing kind of real-time data. If I was to want to, come very small, I could come to July 1st and do September. I'll do the 12th because we're always one day behind. I can then get information, and kind of this information was put this way because we wanted to be able to link everybody together, clinical and financial. So the scheduled activities, this is the verbiage or the things that you would hear a clinician talk about. This is the client, this is the staff, time that they provided or the date, the activity that they did, how long it was. But when we talk about claims, we talk about, payer plan name. They do procedures, not activities. Totally different ballpark, at least in our instance. They talk about billed amount, expected amount. And then we go into transactions, and that's kind of, you're really getting into the weeds. But, in this stuff, we can then click on something, and then we'll be able to actually see that information transposed down here. So I clicked on George's, service on the 28th of July, and then the clinician or the financial folks are able to kind of see what that means. And we can then even go down into the transaction level where we can see that, okay, the revenue is recognized, we did the contractual adjustment, and we got the payment approved, and then they can see kind of all this date and information. So, this allows for there to be, I think, improved collaboration. There's, I've got probably 8 to 10 different use cases that can be done just on this. I cannot express, how important that is to be able to do. I'm going to go back into my presentation, and there's a slide. But here's a run rate analysis, and I'm going to show this because I've already got an example of that I found. This is basically saying, what are things? What is it looking like? I'm looking at expected amount. That's what our finance people look at. I've got a control chart with, up to 2 standard deviations. That's not where we're at this point. Right now, we're at the prior period or previous year in this case example. So, we can see we're a little bit above where the light blue is kind of the current year, the dark blue is the prior year. But what we did was then we started to put that into kind of data below with there actually being indicators. And in this indication, the crisis actually had a downward arrow. Downward arrow basically means it's at least 1 standard deviation from the mean.
Okay.
Again, maybe not exactly what everybody talks about, but I was able to then see, okay, wait a minute, there's $30,000 difference. Is that actionable? Sure, that's actionable. But you know what? I want to know what codes those are. So in this dashboard, it then has basically this table down here, and it's our mobile crisis response. We didn't have as many, and our crisis intervention. And those are down, shows you how much they're down, and kind of, if you were to all add it up, it basically adds up to that $30,000. But it gives you something actionable visually. And as you can see, you can do a couple different chart views. You can do it by units, you can do it by productive hours, and by productive pay per hour. So there's multiple ways that this can be used for both finance and also for clinical if they should want to. So very cool tool. Love it. It's been super helpful in being able to bring it down to the clinical level. This they understand. They understand that this is mobile crisis response and this is crisis intervention. They then can speak to that as opposed to having to go through these other 3 different codes that really are not as big of a bite of money that's missing.
Well, it's a huge step up from, spreadsheet. Malcolm Gladwell says you have to give people a reason to look at a bunch of numbers in a bunch of rows and columns, and your visualization. And I think hats off to you and Icentrix for having these, solutions and dashboards that have, colors and graphs and charts, because it does train the eye to what you want people to pay attention to. We're at the top of the hour here. We have 3 minutes. I'm going to say, Steve, any comments? I have a question or two, and we'll end there. But just so appreciate all of this, just wealth of opportunity. That's what I would say.
Yeah, I would just leave with this slide. I like this slide because it's illustrating what we mentioned at the outset, which is the idea of tools that help us, don't leave all the interpretation up to the user. Don't just throw a bunch of numbers up on the screen and expect the user to know where to look.
Yeah.
We should have tools that help people find insight based on best practice, right? So statistics, we know, is a good tool for telling us when things have gotten out of compliance with what we think of as normal, and that's at the top. But then the idea here is drilling down and being able to flag. So this is equivalent to if you ran 50 control charts yourself, clicking on each one. Instead of doing that, we have the down arrows that's going to tell us where to look next, is the idea, right? So that would be the theme I would want to leave people with, is look for root cause, as you said.
Yeah, and I think, Rob, too, you're clearly a very smart person. Speak a little bit to health and human service organizations doing this alone or doing this with a partner, because I'm thinking that, you with all of your capabilities, you still have joined with Icentrix as a solution partner to really assist you, because this is a heavy lift, this is a heavy load to get to this level of sophistication. And maybe you could just speak to that as a parting remark.
Sure. Depending upon the agency, our agency actually is fortunate in that we do have minimal funds, but we have some funds where we can do analytics, hence my position. However, there's lots of competing kind of projects. And with Icentrix, and I'm going to be like a totem pole for them and put them at the top of it, they're awesome. They know our EMR, they know the data, they know how to put this into effect. They've got out of the box solutions that, they can pool all of their clients they've worked with together. And I don't necessarily have to come up with all of that, or the team doesn't have to come up with that. And it's well worth every cent that we've paid.
Well, look, thank you all. We're at 2. I know we're going to start losing audience, but Steve and Rob, thank you for bringing this to the Open Minds audience and sharing this case study. Fascinating. I hope we'll have a chance to do it again. Please look for your link later for all of those in attendance, and thanks for participating with us today. Thank you.
Thank you.